Good morning. It is Tuesday, October 5th. Welcome into the morning medical update. Glad you're with us. Today, we are talking about using monoclonal antibodies to fight COVID-19. What exactly are they? Who can get them? How do they help? When will they be FDA approved? We've got all the answers for you. Dr. Nathan Bahr is joining us. He is with our infectious disease department, joining to break us all down. We're gonna also hear from a patient actually who was sick with COVID, and he tried monoclonal antibodies, and we're gonna find out how he's doing now. But first, let's check in with Medical Director of Infection Prevention and Control, Dr. Dana Hawkinson. Good morning to you. How are we doing on our numbers?
Well, I'll tell you, Hayes has 12 active infections and 6 in that recovery periods for a total of 18. But here at the health system, we are fairly happy because we have 16 active infections, 5 in the ICU, and 4 of those ICU patients, however, are on ventilators. So a high proportion in the ICU are on the ventilator. We actually saw that before, earlier, before this current surge. We saw that those people that were sick enough to go to the ICU, a high proportion of them were on the ventilator. We still have 36 though in that recovery period, so a total of 52 patients. But overall, our numbers are down. Unfortunately, they are similar with Hays's, which doesn't have as much capacity as we do, as we obviously all know that. But again, Hays has 12 active infections. We here at the KU Hospital, 16 active infections.
Any reporters on the line today? Okay, I do have a question from Donna over at Channel 9. With Johnson & Johnson's announcement that a booster could be coming soon, is this encouraging? Also, do you anticipate any differences between the J&J booster process and Pfizer, since J&J is not an mRNA vaccine? Thoughts on that?
Is it encouraging? I mean, again, I think what we have seen, and there's good data to support this, that even months out from vaccination, the vaccines do what they are supposed to do. Their intent is not to stop you from getting infected if you are exposed. Their intent is to stop you from having significant disease, going to the hospital, having severe disease, and dying, and they all continue to do that. Now, in some groups, especially those that are older, maybe there is a little bit of decline in that effectiveness. But overall, I think that we are getting good data. We are getting as real-time data as we can because, again, we haven't had the vaccines that long. We haven't had this illness that long. So we are getting good data to support that if you do get some of these boosters in these particular populations, you are going to improve that vaccine effectiveness against hospitalization, severe disease, and death even more. And I think as we get further into this, we will really understand what is that term fully vaccinated. We heard Dr. Fauci talk about, well, maybe at some point in time, everybody will be getting 3 doses of the mRNA vaccine, or maybe 2 doses of Johnson & Johnson. I think it's still early to tell. We will wait for the FDA and ACIP guidance when they undergo everything. I know that they are meeting a few times here in the next couple weeks to look at all of that data, answer all of those questions, so hopefully we will have more. But the biggest thing that we want to do is continue to protect everybody. Those people that are eligible that haven't gotten a vaccine really need to go get a vaccine. And we are also waiting for that whole population that is ineligible right now for vaccines, and that is those young children, but hopefully that is coming soon.
Thanks, Dr. Hawkinson. Okay, we're going to get to your community questions here in just a moment, but I do want to turn to our guest and bring in Dr. Nathan Bahr from Infectious Diseases here at the health system. Good morning. Glad you're with us.
Good morning.
So we're going to talk about monoclonal antibodies here in just a moment, but just a couple of questions for you about just your thoughts on the numbers. Dr. Hawkinson talks about our numbers off the top of the show every day. Yep. I want to just hear your thoughts about that and what you're seeing with your patients. What's concerning you? Just kind of give us an overview.
Yeah, I mean, I agree. It's great to see the numbers overall going down. We're happy with that, of course. But it is concerning that we're still having so many sick patients. And I can tell you, I'm seeing some very, very sick patients. And it's, even with the overall trend going down, it's still heartbreaking to see people, deathly ill. I mean, really, really ill. And especially when, as we've been talking about, we have really great vaccines that can prevent most of this. And it's tough.
Can't rely on the treatments.
Can't rely on the treatments because, they're rescue plans, right? I mean, and so it's, what would you rather do? Never get sick in the first place or have these pieces of plans that may be able to pull you back but may not. None of those treatments, including monoclonal antibodies, are anything close to 100%. Vaccines way closer to 100%. Not perfect, way closer than most of these treatments in terms of actually making sure you don't get in the hospital from COVID.
As far as your patients go, have you been able to have those conversations with the unvaccinated? I know sometimes they get so far into the illness that you're unable to communicate, but what are those conversations like with unvaccinated patients?
They vary. For some people, it's, they were scared of something. Whatever it is, they're scared of a particular situation for them. Somebody told them something that made them nervous, and they were just too scared to get it. And so, sometimes you'll hear an outright, "I wish I had it." Sometimes you'll just, you'll ask them about vaccination status, and you'll get a sort of a regret in the tone of the voice and the way they look at you. And that's always hard to see, especially when somebody's really sick. It makes you feel just awful. Sometimes you get a very angry response to that question, and that's a different animal. But oftentimes it's just sort of a realization that they're really sick, and it's tough for them. It's a tough thing to sort of think through as you're struggling to breathe.
Sure, I'm just always interested to hear your perspective from the before and then the after, what patients are saying. Let's talk about monoclonal antibodies for a moment. So we talk a lot about that on this program. We get a lot of questions about it. Yep. So a lot of folks that are watching this, of course, we are not physicians, so we want to find out kind of how they help battle COVID-19. So a question we get a lot is, why, if someone tests positive for COVID-19, why isn't monoclonal antibodies the first route to take? Why wouldn't you just give it to everyone?
Yeah. There's a few answers there. The biggest one is that it is not as simple as, calling in a prescription, taking a pill. There is, these are infusions. They take about an hour to infuse. You have to be watched closely. It's about a 3-hour process altogether. And so, you have to get an IV placed in. You have to get the infusion. We have to make sure that everything goes okay afterwards. Often people are getting towards being kind of sick. Some not so bad when we're able to get them. That's great. Some are fairly sick, and we actually have to say, okay, this isn't the right thing for you right now. You need to go to the emergency room because we need to get you in more intensive care than we have available here. So there's a lot of reasons for that, but a lot of them have to do with essentially the process of monoclonal antibody infusions. It's just not quite as simple as getting a pill. Let's get it to you right now.
So how do you determine who is the right candidate? And then I want to ask you about the process someone might go and seeking it out.
Yep. So we have criteria for who's a candidate. So we have been sort of adjusting our criteria all along. That's based on the evidence behind who will get the most benefit. We particularly want to seek out people that are at the most risk. So this is a antibody infusion that's made. Okay, so this is not like taken from patients, et cetera. This is synthesized in a lab. Mm-hmm. This is made in a lab, and so the idea is to give people an antibody response early, before their own body could make it. Okay, the body will eventually make antibodies, but if you're very immune suppressed in particular, but also if it's just your first time ever being exposed to COVID, you're not vaccinated, for instance, it's going to take a while to make those antibodies. So we are giving antibodies to the person to fight off COVID. So what we're really trying to do is get that response moving quickly to help that patient recover more quickly.
So there is a time frame in which you're trying to work within.
Absolutely, because we know that people are going to develop their own antibody response eventually. We want to start it before that would happen. You could be 3 weeks into COVID, you're going to have your own antibodies. So us giving this treatment isn't going to help at all. So we're focusing on giving it early and giving it to people that are the highest risk. So especially people with immune suppressive conditions, but a number of other conditions as well. And as I said, we have these criteria in place. They're pretty complicated, to be perfectly honest, and we alter them when we need to. So when the numbers go way up, we still only have the same amount of capacity, so we can only infuse so many of these infusions per day, and so we actually have to narrow our criteria a bit when that happens, because we really feel a duty to make sure the people at the very highest risk can get these infusions.
Yeah, it's not just the medication, it's the space to do it in, and it's the staff to make sure people are receiving it correctly.
Yep.
Okay, so if somebody comes in, walk us through, they have COVID, how do you determine?
Yeah.
How do you determine if they would be a candidate? And,
So
and who talks to them about that? Their physician,
Yeah.
you, somebody in the ED? How does that work?
Yeah, we have a big centralized process with a lot of people working on this actually. And our health system has really, I think, done a great job making sure that we have a good process for this. So we have a couple ways this can happen. One is our own internal testing results. So people with positive tests, we have our nurses that call those results back. They actually screen for eligibility. So they look at the various criteria and see if they think people might be eligible. We can also get referrals from both our internal physicians and external physicians. And so that goes through the same process where these nurses go through the criteria, they look, they see if they think the person will be eligible. Sometimes you can't tell based on the information you have. So then they call them and they talk through it and they say, hey, we think you might be eligible. Let's talk through these issues and see. And if they think they probably are and the person wants to go forward, then we set up a telemedicine appointment with nurse practitioners. We have a team of nurse practitioners that helps out with this. And they screen them and make sure they're well informed about, the risks and potential benefits. And after all that, then we set them up for an infusion. And so then that involves going to our infusion center, making sure that, we can get them in the proper time frame. So it's a involved process.
Well, as I'm sitting here listening to you list off all the processes that happen, this would explain why people ask quite often, why can't just anyone get it at any time?
Yep.
It
isn't that easy.
It is not easy. So,
No.
so again, don't rely on the treatments. Get vaccinated.
Right.
Last question before we get to some of our community questions out there, because I know you've got good questions coming. FDA approval.
Yeah.
What does that look like?
So what we have is emergency use authorization for these treatments. So this is not, the full FDA approval process. This is a very strict process. So what that means, in addition to our own criteria, there are criteria with this emergency use authorization that the patients have to meet. So there are certain things with that emergency use authorization that we can't go outside of, period. So it's different than a medicine that's fully FDA approved. Doctors can prescribe it off-label. So, there's a lot of examples of where that's done commonly. That's not something that can be done here.
Okay, so I have a question. People have concerns about the vaccine being on emergency authorization. So do people who qualify for the monoclonal antibodies, do they often question or turn it down?
We see some
Because
of
of that?
that.
Okay.
We see some of that, but it's interesting. We also see plenty of unvaccinated people that are very willing to do this treatment that's under emergency authorization.
And what do you say to that? I mean, just what do you make of that?
Well, I think part of it's probably they're scared at that point, right? I think it's a lot easier to say I don't want to be vaccinated when it's a hypothetical thing that you can tell yourself will not happen to you. I think it's another when you're starting to feel kind of rotten and you have a positive test for COVID. I think the calculation in your mind maybe changes a little bit with that.
All right, so let's get to some community questions. And Dr. Hawkinson, I've got one for you. Isaac wants to know, with Hayes numbers high and main campus relatively low, how many internal transfer requests are there from Hayes to the main campus? Do we know anything about that? And just what do you make of that disproportioned number?
Yeah, I don't know about the transfer requests. We do have an executive team that does field those transfer requests. I'm sure we have gotten them, but it's really hard to say exactly what. But we do also know that their capacity, just their total number of hospital beds, is much smaller than ours. So, but I haven't heard exactly how they are doing on their capacity and their ability to treat those patients. So it's really hard to tell and understand the need for them to transfer either those patients or patients who have other common medical problems which are unable to be treated there because those beds are being filled up with COVID patients.
Dr. Bahr, question for you. Do you anticipate a time when the monoclonal antibodies will be available as a simple injection as opposed to the infusion-based treatment that we see now? This person feels that would be a big game changer for those who might have been exposed. What is the future of monoclonal antibodies?
There is a potential to do subcutaneous injection, so just below the skin. That's available as an alternative. And they phrase it pretty specifically. They don't want this to be standard of care right now. But that still requires the same screening process, the same observation process. And so it's still a pretty lengthy process. It would, give you a little more time. But it's, still a lengthy process, still an involved process. And it's not going to be anytime soon, like a flu shot where you can get your shot in your arm and walk out the door
be on your
too long.
way.
Yeah.
It's still an infusion. So we caught up with a patient who was receiving monoclonal antibody treatment, the infusions. We're going to hear right now why he says this treatment has given him hope.
I am so grateful for something like this. I'm susceptible to a lot of things. I have no immune system, my liver problems, and also diabetes. With all those things, I felt like if I did have COVID, it was going to be critical. If it happens, I wanted to find out as soon as possible. I've experienced them all right now. Terrible headache, tightness in my chest. I felt like my heart was having trouble beating properly, and what else was there? The smell is gone. From what I understand, it will help smooth out the rocky road to come yet, and that this has given me some hope that I won't be one of those that are on the news in the respirator. People gotta wear masks, people gotta stay distanced. This whole political issue over masks is crazy. It's about helping people, not necessarily yourself. Because by wearing a mask, somewhere I came across somebody that maybe didn't, and now I'm here.
And I did reach out to Paul yesterday, and he is doing quite well. So that is a good outcome. But when you hear a story like Paul's, you see these patients I know that you're handling day in and day out. Just kind of what are your thoughts about that? You're glad there was a good outcome, but you don't want it to get to that point.
Yeah. And you feel for Paul when he's talking about how he's feeling, how he sort of, you can just hear the sort of fear in his voice, right? He knows that he's at risk, and he's kind of desperately pleading with people, help me, because I have an immune system that is not going to let me fight this off as well. So I'm so glad that the treatment worked well for him. But I would just reiterate, the vaccines are way better. So absolutely, we will try to get you in if you're at risk for this monoclonal antibody treatment. There's a good chance they can keep you out of the hospital but the vaccines are so much better.
Yeah, and we're making that clear across the board today as we talk and go into detail about monoclonal antibodies and how good they are. But again, nothing's as good as the vaccine. But are there some people who it just does not work well for, and you find out in the treatment that this isn't going to work?
Yeah. I mean, we have, I've just recently looked through our data on this again, and we've infused about 700 people with monoclonal antibody infusions. Our rate of either hospitalization or death amongst those patients is just under 3%. And so this is a group that we would expect that to be a lot higher. Yeah. We would expect it to be, 7, 8, 9%, something like that. So it definitely helps, but there are absolutely people that are that still go on to need the hospital, that still even unfortunately sometimes die despite these treatments. So, again, vaccination is the way to go, but we will absolutely try to get this to anybody that's at risk because we want that benefit if we can do it.
The cost of monoclonal antibodies, we get that question a lot.
Yeah, so it's, the medicine, since it's through this emergency use authorization, the types we're using are, the actual medicine itself is free because the government has paid for it. So, free. It's not actually free, but it's free to the patient.
Yeah.
But there's the infusion center and the telehealth visit and those sort of things, and those are charged to insurance and that sort of thing.
Dr. Hawkinson, we do have a reporter question for you. John wants to know your thoughts on AstraZeneca today seeking EUA from the FDA of a so-called antibody cocktail that the company claims can prevent symptomatic COVID-19 just like the vaccine. I know nothing's just like the vaccine, but what are your thoughts on that?
Yeah, I think it was the monoclonal antibody that they're looking for. So I think it's really going to be used in the same way as the current monoclonal antibodies, really for a treatment. In certain select cases, they have certainly looked at monoclonal antibody in that prophylaxis period to help prevent. For instance, if you are in a nursing home and you are in those high-risk situations. But again, this is one more thing that we can use that will help us defend against this disease process. So I'm all for it, looking at the data and really using it in those circumstances when it is in those high-risk situations and that we can see some benefit from it. And I don't know what Dr. Bahr's thoughts are as well.
Yeah, I mean, I think the first thing I would say is I want to see the data on this, like I do with any sort of new treatment that's being talked about. Some of the time we're seeing press releases and things like that, and there's more to it than that. So that's my sort of first thing is I want to see the data behind it. I think one place where this would be helpful if it is able to be used just as prevention is in particular with those really immune suppressed patients that may not respond as well to vaccination, because the vaccination, remember, it tries to give instructions to our immune system on how to respond, and so this is a different approach in those patients where their immune system can't respond as well, even with good instructions. Perhaps giving them antibodies to be in the system could be an option, but I gotta see the data before I would be anywhere close, and obviously they would need to be approved before anybody could give it.
That's what you're paid for. You look at the data for all of us.
I sure do.
That's your thing.
and I believe what they're talking about as well is also supplementation or just an adjunct to vaccines if you don't respond or if we know you're immune suppressed as well. So it is nowhere near a replacement for vaccine. Vaccine should be the first thing that you use, and then everything else after that, just as Dr. Bahr had talked about early on in the show.
So I want to get to another media question, and it is on the same topic of the AstraZeneca requesting the emergency use authorization. But I just want you to hear this part of the question from Fox. They say that late-stage trials show that the treatment reduced the risk of developing COVID-19 symptoms by 77%. Have you seen the AstraZeneca data? You're waiting on that. What do you think what would this approval mean, and what would the treatment mean for us?
Yeah.
Just reiterate, just in case they're joining us.
One caution I always kind of give people is when you read press releases that talk about dropping something by X%, that sort of thing. We need to see the full data to understand what that means. So if you're dropping it from 1% to 0.5%, that's a big relative drop. That they can claim a 50% drop in that case. But we need to see the absolute numbers to truly understand what that means. So it's a little tricky sometimes. Press releases.
That's all you're going by.
Yeah.
That's not enough.
So that's why I say gotta see the data.
And I think the key to this too is, again, these are lab-made antibodies, so they are produced in the lab, much like the other monoclonal antibodies. We have to understand that for vaccines, people don't want to put anything else into their body. So are you going to be doing this? Are you going to be consistent in your thoughts as well? But again, these are not a replacement to vaccination or the non-pharmaceutical interventions. These are an adjunct to help those people that don't respond to the vaccine or who have not mounted a good enough response and are still at risk of going to the hospital from COVID-19. So it is similar to what we have seen, but also if you remember, and I think this might be maybe two antibodies together as well, like a cocktail. But again, we need more information. And any time you are dealing with specific antibodies, you have to understand that there is that potential for the virus to elude those antibodies. And we saw that happen with the Eli Lilly product when that was pulled off from the EUA. However, with the resurgence of Delta, we saw that now those antibodies do react to the Delta virus, so it was brought back in. But just anytime you have specific antibodies, just understand that there is that potential that virus, through mutation, could avoid those and evade those antibodies as well.
And for those of us just joining us now, or if you had any tech issues earlier off the top of the show, Dr. Bahr, I'm getting some questions about who qualifies, but could you just go over the qualifications of monoclonal antibodies for those just joining us?
Yeah. I'll go over the basics.
basics.
There's some nitty gritty.
Right.
These are, so you have to be within 10 days of your symptom onset. You have to be over 12 years old. We have to have a positive COVID test. Those are all sort of the basic criteria. And then we have more specific things. So, age over 65, a number of comorbid conditions, things like, immune suppression for, say a rheumatologic autoimmune type of disease, immune suppression for cancer, just active cancer in general, certain patients with diabetes, certain patients with heart disease, lung disease, things like that. So they're actually pretty broad. We in the past had said, if you didn't have immune suppression or you weren't elderly, you wouldn't be eligible at our site if you were vaccinated, simply because of capacity issues and weighing risks. Now we're able to make vaccination status not an issue, essentially. So we've been able to expand a bit because we have more capacity than we have had in the past.
Monica asked if kids can take monoclonal antibodies. You mentioned 12 and over.
Yep.
What kind of results are we seeing with kids?
So we've given a lot less in general to kids at our facility. So I think it would be pretty tough to give any meaningful info on results. But there are certain kids that are eligible. Obesity is part of that. They have to be over 12, as I mentioned. And then there's a number of other conditions as well. So, if you're a child that's chronically dependent on, like a tracheostomy, things like that, if you have some congenital issues that have affected their life, those folks can be issued this medicine too. So there's certain kids, seems, as far as I can tell, it's working as well, but our numbers are so much lower in kids than they are in adults that
It's hard to tell.
It's kind of tough to tell. Yeah.
So Wanda wants to know, can you take monoclonal antibodies if you're pregnant?
Yes.
Okay.
That was a quick answer.
Quick answer. I like that. Does that mean because you're immunocompromised, suppressed? Does that would fit that qualification?
Yeah. So in pregnancy is actually something we specifically pull out, and the FDA has specifically pulled out as sort of a priority group.
Oh, wow.
And so, yes, with pregnancy there is some degree of immune suppression. That's why, the woman is able to grow a baby, right? Because their immune system is able to sort of to adapt to that. So yes, absolutely, it's an option. We haven't had any safety issues with it. The broader data has not had any safety issues with it. And I'll just reiterate, with the Delta variant, this has been particularly hard on unvaccinated pregnant women. And I would just encourage, one, get vaccinated. That's extremely safe in pregnancy, and that's the best way to make sure you don't end up in the hospital. But this is also an option, vaccinated or not. We can still do monoclonal antibodies to try to save somebody from going down that route.
Dr. Hawkinson, an easy one for you, I think. Teresa says, should I get vaccinated even if I had COVID?
Absolutely. We have more and more evidence. So first of all, the bottom line is the CDC recommends vaccination after infection. There's no minimum time between getting infected and then getting the vaccine, although we do want you to wait that 10 days of isolation so you're not out in the community spreading the disease. But there is more and more basic science and benchtop research showing that those who were vaccinated after infection have actually a wider breadth, have more neutralizing antibodies to those variants of concern compared to people who just got the infection. And so this applies to the variants of concern that we know about, but also probably applies to those variants of concern that we don't yet know about, because what the vaccine does is allows that immune response, those B cells that make the antibodies, and those T cells to further expand. And when they do that expansion in your body, in that immune system, they are able to then recognize further variants, further changes in the spike, and other changes in the virus as well. So it is to your advantage to get vaccinated after you have the infection, especially if you had mild infection.
Okay, Cindy wants to know, Dr. Bahr, are monoclonal antibodies used for other illnesses like cancer, other treatment for other things? Yeah,
that's a good question. And yes, this is not a technology that is brand new for COVID. It's certainly something that's been used for cancers, for autoimmune type of diseases. These have been employed for quite a long time, and for certain other infections, there's been an effort to use these as well. I think this is a very wide-scale, rapid effort for COVID. Obviously, this is a pretty unprecedented situation in quite a long time. But this is a type of treatment that medical providers have a lot of experience with, actually, in other conditions.
Sam is just joining us and wants to know if there's any side effects from monoclonal antibodies.
Yeah. So, it's a medicine. So I always say, any medicine, there's potential for some side effects. And so we haven't seen a ton of anything severe, thankfully. We've had a couple folks that have had infusion type reactions. And so that's not an unexpected thing with any infusion, that you would see some people have that. Thankfully, what's happened really in all those cases is stop the medicine, then the reaction stops, everything's okay. And then the other thing is just, the reported side effects are things that essentially, it's pretty hard to tell if it's from COVID or if it's from the infusion, right? So it's things like nausea, vomiting, headache, stuff like that. And so whether that's from the medicine or from COVID, I think that's pretty tough to guess. But those are the other things we always counsel people about, that's possible.
Are there different types of monoclonal antibodies? And how do you know what's right for you?
Yeah. Well, a lot of it comes down to what's available. And so Dr. Hawkinson mentioned earlier that, there's some of these, the single monoclonal antibody treatment, the bamlanivimab that we used previously, we know that's not effective on its own anymore. So we've not been using that for quite a long time. And I guess I can say, trust us a bit, because we are making darn sure we know which variants are out there and which monoclonal antibody products are going to work best against them. This Regeneron product we've been using for a long time as our primary product, works really well against Delta, works against some of these other variants that we've been concerned about. So usually you're probably not going to have an option with it. It's probably going to be, well, we have this one. Do you want it? So it's usually going to be more of that sort of situation.
As I tell my kids, you get what you get, you don't throw a fit.
Yep, that's right.
That's what you get. Okay. So Lori says, my 77-year-old dad is diabetic and has chronic kidney disease and is fully vaccinated. Good news. But he is under the impression that this type of therapy would kill him if he had a breakthrough case. What are your thoughts?
That's not right.
No.
Yep. So it would not kill him. It would potentially be helpful for him if he has a breakthrough case. So that would be a person that I would say, you're over 75, there's a good chance, the vaccine's going to help you, but it may not give you quite as much benefit as if you were 25, because your immune system just isn't quite as robust when you're 75. And so I would absolutely want that patient to think about monoclonal antibody infusion.
And he's vaccinated. Is vaccine status important in monoclonal antibodies?
Yeah, so we used to, there was a time when we were saying if you're fully vaccinated, if you don't meet certain criteria, that makes us think you wouldn't respond as well, then we wouldn't give it. But we have the ability to do that now in large part because the case numbers have been dropping.
All right, Shirley wants to know, is convalescent plasma an antiviral? Are you still using that for COVID patients?
We are not really using that anymore. The data on convalescent plasma didn't really pan out. The way that was done in the U.S. was a little different. So we didn't, this was given in this big program immediately, and it was kind of really put throughout the country real quickly. The studies kind of followed that. And so the studies, especially for hospitalized patients, really didn't pan out. They didn't work very well. We haven't had a lot of data on people outside of the hospital. The only situations where we will consider it at this point are in people that are in the hospital with severe immune suppression, where we think that getting them these are essentially antibodies from other people that we're giving. That's what we're really focused on with convalescent plasma. And so those are the only situations we'll do it. So say somebody has an extremely suppressed immune system, they're in the hospital, those are people we could consider it in, but that's a rare thing that we would consider it, to be perfectly honest. The data really hasn't borne out that it's helpful.
Terry wants to know, are antivirals becoming a thing like antibiotics?
Well, they've been around for a long time, but antibiotics in general are a lot more effective than antivirals. And so there are certain viral infections that for a long time we've been able to to use antivirals for herpes infections, for instance. Very commonly we use antiviral medicines. But there's other viral infections where we've never really had an effect of antiviral. And so, this is, obviously there's more interest in developing effective antivirals when you're talking about a pandemic that's killing a lot of people. You want to be able to intervene quickly with these. In order for an antiviral to work, you got to get it to somebody quickly. And, that's why, this Merck product that's an antiviral, if it works out, would be exciting because it would be a pill that you could prescribe to somebody early on.
Dr. Hawkinson, Lindsay wants to know, should my first responder husband get his Pfizer booster today if he got his first dose back in January?
Yeah, I mean, certainly the recommendation would be those people that are 18 to 50 who are in those high-risk situations where they are at risk of exposure, they may get it. So I think that that is that decision that needs to be made. But certainly he would fall under that category. And then obviously if there are medical problems or comorbidities that he has as well, then it would be recommended for somebody to get that third dose.
And Maggie wants to know, any idea when the Moderna booster will receive authorization?
Yeah, I think we're still waiting, and this goes back to the Johnson & Johnson question as well. Moderna and Johnson & Johnson people who got those vaccines did feel a little bit left out because a lot of the data has been with Pfizer. But I think we are expecting this in the next few weeks, with the ACIP committee meeting again several times in the next couple weeks to look at some of these questions, and that will include Johnson & Johnson and Moderna. But what we can say still is that even if you got the vaccine in January, whether it's Johnson & Johnson or Moderna, we know that you continue to have good protection against going to the hospital, going to the ICU as well. So I think, everything as far as that goes, you are still very well protected. I think a lot of what the case has been for these boostings, if you are not over 65 or otherwise immunosuppressed, is that ability maybe to help reduce transmission in that time period from 1 to 3 to 4 months after vaccination. So I think that's the important thing to note. That came up early when we heard the Biden administration talking about boosters. Even though they continue to offer great protection months out from vaccination, the question is, can we still have reduced transmission rates in this short time period moving forward? That was one of the reasons for offering some of these boosters to those people who were not over 65 or otherwise immunosuppressed.
Dr. Bahr, you went over this just a bit, but Lonnie wants to know if you can just help us better understand why antivirals don't work when you've given them several days out.
Yeah. So we see with COVID, we actually have a lot of data on this when we in general in population type of numbers see the virus become less of the problem, right? So what we see is early on, imagine I have a nice chart here, the virus really goes up, and then as time goes by, the virus itself goes down, and those people that are in the hospital, it's not, oftentimes, especially once we move further along, it's not the virus. There's not much virus actually in their system at that point causing problems in many patients. It's that immune response to the virus, and that getting out of control actually can cause some of the damage. So if you're over here and your virus is really high, giving an antiviral at that time is a good idea. If you're over here where the virus is very little, we can give all the antiviral we want. It isn't going to do much good.
Margaret says, what does it mean when we say monoclonal antibodies are made in a lab?
Yeah.
What lab, where, how? Is that safe to put in our bodies?
Yeah, that's fair.
Go into that for us.
Well, not a nefarious mystery lab or anything like that. It's So this is a process that's pretty well established at this point, and there's a lot of nitty-gritty detail to it, but it's a safe, well-established process that is actually very straightforward to do from the folks that make these at this point. They just need to know, what the antibody looks like, what is the actual, protein encoding information they need, and then they can make that antibody. So it's, the companies that make these have their own labs that do that essentially. But it's a straightforward process. It's not anything that's, going to introduce some toxic anything into you or anything like that.
I think made in a lab throws people.
Yeah, that's fair. And my point in saying that is essentially that it is, it's not like plasma where it's coming from another human. It's something that's made specifically for this purpose, just like any other medication is.
It's an extremely regulated
Yes.
production.
Okay, that makes
Yeah.
us regular people feel better.
Yeah, yeah.
Okay. So, question, Simone wants to know, will monoclonal antibodies prevent long haulers?
I don't think that's something we have a good handle on. And so, again, we're seeing a lot of data that, a third or more of people that get COVID infections have long-term symptoms, when we're talking 6 months, over a year, things like that. And we don't really know monoclonal's role there. But we do know if you can prevent the infection entirely, you do better.
Tracy says, how fast do monoclonals work? She said her friend said it felt almost immediate. Is that possible, or is it in her head?
I'm glad to hear that. I don't know that it's quite that quick, but you certainly would expect to see some effect, hopefully the same day. I'm sure there's some piece of that where just feeling that you're getting something that's actually targeted towards helping you is probably feels pretty darn good. But I think I would expect it to, within a day start showing some signs of improvement too.
Couple more questions. Jody wants to know, I'm in healthcare and had Moderna back in December and January. Should I have a booster, Dr. Hawkinson, right as you take that sip of coffee?
Yeah, again, right now, all of the vaccines look good. The data with Moderna continues to look good for preventing hospitalization, severe disease, and death. We are going to be waiting for the Moderna review, the data review from ACIP, and see what their recommendations are. If there is recommendation for booster, obviously you will be, I suspect that any of the boosters that are recommended, really the guidance will probably be the same or very similar to what the Pfizer recommendations are now. So there are groups that are recommended to get boosters, and then there are groups that may get booster or additional dosing of Pfizer, and includes that group who are at those high risk of exposure because of what they do and what workforce they are in. So therefore, it goes down to personal risk evaluation, and do you feel like you want to get it? I think it's certainly reasonable, but we also have to understand exactly why. Do we feel that getting it, you will continue to be very highly protected to help reduce transmission even further? Should you get it within those 3 to 4 months after getting that booster dose? That's important. But right now, you are still very well protected. So I think we just have to wait to see what the full data is. And then, again, I suspect, and I don't know if Dr. Bahr has any thoughts about this, but we know that the wording has been confusing, the messaging has been confusing. I'm hoping and expecting that really the recommendations will be the same or similar to what Pfizer is right now for that Moderna mRNA vaccine.
Anything to add, Dr. Bahr?
No, you covered it really
You
well.
did pretty good. Okay, last question is from Deb, and I want to ask both of our doctors this question. She said, I just don't think we're ever going to see that high percentage of vaccinated, that 85-90%. Kind of seems like a pipe dream right now. What are your thoughts as it stands today? Dr. Hawkinson, I'll start with you.
Yeah, I would agree. I'd like to be optimistic, but also realistic. I would agree. Unfortunately, we still have large groups of the eligible population that are not wanting to take it, unfortunately. In addition, part of that are still minors that are 12 to 18 that really need, in a lot of places, parents' permission to get it. So that will affect it as well. And then, of course, once you get to the possibly or soon to be eligible population of those children 11 to 5 or 11 to 2, again, that's all going to be parents' permission at that point in time. So, I think that is probably true, that we will never reach that full amount of vaccinated, but hopefully vaccinated plus some little or minor immunity from those people that have been naturally infected will help to get towards that as well. But certainly, the more percentage and the more people that we can get fully vaccinated, the better off we're going to be, especially when you're comparing just those that have had the natural infection as well. So I would tend to agree, but we have to keep endorsing, giving this message to get vaccinated, because right now we are doing well. Right now is the time to vaccinate, because when we look ahead now 1, 2, 3 months, especially as we're getting into the holiday season, We would like everybody vaccinated by that point in time, again, to help reduce transmission, especially as we will all probably be gathering indoors, wanting to meet with friends and family during those times, those gathering times that we've traditionally used. So I think it's important now to really get a head start on the vaccination and keep going. And when children are able to get vaccinated, get them vaccinated as soon as possible as well.
Dr. Bahr, pipe
Yeah.
dream or reality?
It's a kind of a sad way to end.
Sorry. Please say you have better news. No.
I mean, I kind of agree with Dr. Hawkinson, but, you know, I guess what I would say in terms of sort of a plea to, like, we all have a role here. There are a lot of people out there that can make a decision that can change what looks to be a reality. And what I would say is, you know, think through what you're talking about here, because if you're not getting vaccinated, what you're going to end up with very likely is getting infected at some point. And so would you rather get this vaccine, have a sore arm, maybe get a fever even sometimes, or put yourself at risk to die? Because truthfully, that's unfortunately what we've seen so much of. And, you know, we hit 700,000 deaths recorded in the U.S. not long ago. That's recorded. The numbers are certainly higher than just the numbers that are recorded. Think about that for yourself, but think about that for your family. Think about what it would mean to them if you died from COVID. So that's sort of, I guess I don't know exactly how to every person's a little different in how they think through this stuff. But to me, if it's not protecting your community, protecting your loved ones, that sort of thing, at least think about your personal likelihood of surviving or getting really sick. One thing that you hear quoted a lot is, well, there's X percent chance that you're not going to die. That's true, but there are very bad things that aren't death. So if you're in the ICU for a month and you live, obviously we're really excited you live, but that's a long road to recovery after that. And what we're seeing is people that were 28-year-old triathletes and can hardly walk across the room now a year later. That's awful, and that's something we want to prevent. That's why we're pushing vaccines. There's nothing else behind it. We want to prevent that sort of situation.
Dr. Bahr shooting us straight this morning. We appreciate that. So I
add
usually
some credibility to our show.
Right, I know. Up in the game for us. We appreciate you being here. I always end with just final thoughts. You just had some great ones, but anything you'd like to add as we head out on this Tuesday? I'm just pushing you.
I jumped in line a little.
No. You had a great answer, but what else is on your mind,
Dr.
Bahr?
What else is on my mind? Well, masks are still good too, so maybe that's something to add. So just keep masking, keep trying to prevent other people from getting ill too.
Good to see you. Come back.
Thanks.
Dr. Hawkinson.
Yeah, I think, again, we're all optimistic because cases are going down. The hospitalizations are going down. We are getting into colder months. We know that people will want to be gathering in the next couple months. Please continue to do those smart things, especially in those high-risk situations. Please get vaccinated when the vaccines are available for the population of 11 to 5 or 11 to 2. Please get your children vaccinated. Help keep everybody safe. We hope that there's not another surge. We anticipate that there probably will be. We have to be prepared for that. But we can decrease that surge as much as we possibly can by getting everybody vaccinated. And so it starts today, and continue to tell your friends and family who aren't vaccinated, ask them and talk with them. Please go get them vaccinated.
Great advice from both of you. Thank you so much. And thank you for being with us today. Tomorrow he is back. It is Open Mics with Dr. Stites.
Dun, dun, dun.
Yep. Vaccines are just around the corner. Dun, dun, dun. Is that what you said? Vaccines just around the corner for kids ages 5 to 11. But some parents are still hesitant. We answer your questions, plus how the vaccine impacts children with certain chronic diseases. That is tomorrow morning, starting at 8. Have a great day. We will see you then.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.